a bit of a virtual presentation. There's not a lot of data on PI3K delta inhibition in myeloma, but I think that there's a reason why we think that the PI3K axis is really important in targeting potentially for myeloma. And when you see that the most common mutations are downstream in the PI3K pathway, I think it certainly makes sense to think about how to target this, and I'm going to potentially show you some reasons why I think we failed to date to have success in that area. So the AKT-PKB pathway, I think, is important for a number of reasons. It's really important for proliferation, survival, differentiation of cells, and it does potentially represent one common pathway by which many cell surface signaling pathways can be blocked at one time. And I'm going to show you sort of an intercept concept that I think PI3K really is important for. Additionally, cells that live in the bone marrow microenvironment do so because they are nourished and fed there. And part of what those nourishment and cytokines do is provide signaling through the PI3K pathway. And so when cells become microenvironment independent, they do so by auto-activating the PI3K pathway. So it becomes an important part in high-risk disease as well. So this is a really complicated figure sort of showing you the many fingers or tentacles of the PI3K pathway. The only reason this figure exists is because I had a fellow who took 6 months in the lab, and this was what they did for 6 months. So she did a great job, and I tried to see if I could use it whenever I can. One of the important parts that I've circled here in red, in some of the red areas, are different ways to try and get to PI3K. Because obviously you can block PI3K all the way up here at the top, but there are many downstream effectors that can reactivate or cause reciprocal activation of the pathway. And so you usually need a multi-pronged approach to be successful in the long term, which I think is an important reason why we've not been quite as successful as we would have liked. Now, I think it's important to realize that all the cytokines you see on the top here, IL-6, IL-1, MIP-1 alpha, VEGF, SDF1, these are all different cytokines that are present in the bone marrow microenvironment, and they all do signal to activate PI3K. And in fact, with crude tool compounds like LY294002, you can block that activation in a number of different cell lines. And I think that's an important thing to keep in mind because PI3K is not activated by 1 or 2 or 3 growth factors. It's activated by 5 or 7 or 12 or 15 different growth factors. And so it does sort of serve almost as a linchpin, if you think about it, to getting multiple different pieces blocked at one time. Now, we do also know that blockade of using pan-PI3K inhibitors can cause some level of growth arrest. And this is using, again, some of those tool compounds like LY, wortmannian, and rapamycin for mTOR inhibition as sort of a control. And what you see is that at really high doses, you can clearly block the proliferation of some of these cells. Whether you actually kill them, though, is a separate discussion. I'm going to show you some data about that. And I think that really is a major reason why we failed to use PI3K inhibitors successfully. We do show growth inhibition with doses of drugs that are probably not clinically achievable. 50 or 5 or 10 micromolar of the LY compound, even if it was workable, is not a clinically achievable dose. But growth inhibition may not necessarily be the answer that we want. So Don Durden, who is a pediatrician, used to be at Emory and is now on the West Coast, came up with this intercept concept for myeloma, and that is you've got all these different cytokines that signal through surface receptors and do so all through PI3K and AKT, and actually created a prodrug called SF1126, which was a more soluble version of the LY compound, and linked it to an RGD determinant so he could get it within the bone marrow. And so we actually did some preclinical work with SF1126 and actually showed we could modulate AKT. It's a pan-PI3K inhibitor. It's not a selective isoform inhibitor. And we actually did show that we could block some of the downstream pathways in a couple of myeloma cell lines as well, and that effect occurred at 5 and 10 micromolars. Again, clinically unachievable doses, but we did show somewhat of an in vitro effect. And then we started to look at the effects in terms of growth inhibition. And this, I apologize for the funny legend here, this is cell growth inhibition using an MTT assay. And what I think you'll see is when you're in the clinical range, 5 micromolar or less, you do see some growth inhibition, but when you start to look at an Xn5 staining, you actually don't kill any cells at all. Which is sort of counterintuitive. You would think that by blocking all those major growth factors, you would actually kill cells. But we did this multiple times with multiple different pan-PI3K inhibitors and never showed significant apoptosis at doses of less than 10 micromolar. And even if you push yourself and say less than 5 micromolar, we never really killed anything. And so we started to wonder, why is it that we're seeing that discordance between MTT assays saying growth inhibition can be pretty striking, but no real cell death? And part of what we demonstrated was that you actually induce G0, G1 arrest. You prevent cells from progressing through cell cycle, so they're not able to go on and proliferate like they normally would, but they're also not dying. They're sitting sort of in G0, G1. And in fact, we linked that sitting in G0, G1 to downregulation of P21. And when we then overexpressed P21 in those same cell lines, we were able to completely block the effects of PI3K inhibition on growth arrest. And so I think a lot of what we're seeing with pan-PI3K inhibitors was actually growth arrest by P21 downregulation. We thought it might have to do with P27 upregulation, but when we silenced and overexpressed P27, it actually had no major impact on cell cycle arrest at that time point. So based on this idea, we thought, and then there was some work from Dr. Anderson's lab looking at the selective delta inhibitor Cal-101, idelalisib, I can't say that. Thank you. There we go. You guys know how to say it better than I do. Which suggested that there was some potential unique actions to that. Not a lot of cell death was induced with that as well. And so we went back and started to look at what isoforms are expressed in our 10 to 12 myeloma cell line panel here. And you can see there are a few cell lines, and I'm going to point to L363 in just a second. L363 doesn't express a lot of PI3K delta. Interestingly enough, if you combine both gamma and delta, you actually get a pretty good representation that doesn't require you to use alpha and beta, which are the more common sort of housekeeping PI3K inhibitors. And so strategies looking at delta and gamma together might be something that make a lot of sense in heme malignancies. We also knew from data from Ken's lab from several years ago that bortezomib activates phospho-AKT, and that had been shown with carfilzomib as well. So part of the rationale behind what our thoughts were is that if PI3K alone may not induce sufficient apoptosis, perhaps we should combine it with a proteasome inhibitor with the idea that by activating and making the cells dependent on AKT for survival, we could then come in and undercut them with a PI3K inhibitor, selective isoform inhibitor. And we actually did this with a PI3K delta inhibitor called TGR-1202, which is now in phase 1 and phase 2 trials in CLL. I know MD Anderson has the trial open right now, and it's thought to be a little bit more selective than the Cal-101 compound with a different safety profile. And in fact, in cell lines, we started to combine TGR-1202 with carfilzomib, specifically looking at cell lines that overexpressed or had a preponderance of dependence on PI3K delta, and U266 was one of them. And as you can see, this is apoptosis, actually. This is not a growth arrest, and you can induce almost pretty synergistic growth apoptosis through the combination. We then started to look at a lot of different cell lines, and as you can see, there's differential expression, and so this raises the idea of biomarkers for predicting response. Are there cells, are there myeloma patients that preferentially overexpress or dependent on PI3K delta? And if the answer is yes, then perhaps they would be good candidates for combination strategies using these PI3K delta inhibitors. Although the one that didn't really make sense was L363, which expressed lower levels of PI3K delta than some of the other cell lines that were much more sensitive to the combination, as you can see up here in the top. Now, one of the things that doesn't necessarily make sense, and this is a work in progress, as you've heard from some of the investigators as well, is the idea that if you're using a selective PI3K inhibitor, you should see downregulation of phospho-AKT in the combination. And in fact, we're not seeing significant downregulation of phospho-AKT. What we did see was downregulation of mTOR, particularly in JJM3, where you start to see, at 12 hours, you start to see combinations that suggest that mTOR, phospho-mTOR, starts to go down. And what we think that might have to do with is that you still have alpha and beta activity for PI3K, so you're still going to phosphorylate AKT, but the net effect may be much further downstream on mTOR and on FORCAD signaling, which may eventually get you the end result you want without having to mediate through a regular phosphorylated AKT, at least in a standard approach. So that's just sort of a short little pathway through this. I think our preclinical data suggests that it certainly is a reasonable target for combination therapies, and we're actually proposing a trial with TGR-1202 in combination with carfilzomib. I think it's an interesting idea. It would not be for everybody. It would probably be for patients or subsets of patients that preferentially overexpress delta. My sense is, and I don't have data to say this, and we'll know this actually potentially from some data from the COMPASS trial, but my sense is that using RNA-seq, it's probably the high-risk patients who may have overexpression or dependence on PI3K delta, and in which case this may be a reasonable strategy to approach those patients. But again, it's not going to be for everybody, and you probably need a combination approach for it to be maximally effective. So I'll stop there.